Hi, everyone. My name is Rohit. I'm one of the PGY3s. I'll be talking today about lymph node dissection and prostate cancer. This has always been a reasonably controversial topic, and over the last 8 years, three other residents or fellows at this program have discussed this at our grand rounds, most recently Dr. Gavimi in 2021. And as some of you will know, some healthy debate has been reignited as of late with the recent publication of a secondary follow-up analysis of a large RCT out of MSK. Thanks to Dr. Manis and also Dr. Dowdek for providing me like a bunch of resources for this presentation. Now, my first objective, geared mainly towards juniors, is to review some of the general justifications and conventional risks for lymph node dissection and prostate cancer, to go over the anatomical landing zones for lymphatic drainage of the prostate, and to describe the conventional template dissection boundaries for prostate cancer. After that, I want to critically appraise the evidence for comparing the efficacy of different dissection templates for different categories of localized prostate cancer, and then speculate about the mechanisms for differences in efficacy. After that, I want to explore the emerging role of preoperative PSMA-PET, either in guiding or even obviating pelvic lymph node dissection. Along the way, I'll also review the evidence for a number of related topics that might influence decision-making vis-a-vis PLND, general comparisons of RP versus RT, surgical techniques for mitigating the risks of an extended PLND, and so on. Of course, I should also acknowledge where I'm doing this presentation and that I have no personal disclosures. For the sake of any medical students and juniors, we should quickly review the pelvic lymph node dissection in elementary fashion. Prostate cancer can spread through lymphatic channels, and while low risk, less aggressive prostate cancer almost never does this, intermediate to high risk cancer can do it fairly often. So oftentimes in intermediate unfavorable or high risk prostate cancer undergoing a prostatectomy, that person is going to get their pelvic lymph nodes along the internal iliac vein mostly removed either on one side or on both. And this is one of the few parts of the surgery you can actually directly see while being a second assist. When someone is doing a pelvic lymph node dissection, there are a few main goals. And the first goal is for better pathologic staging. So before the person undergoes surgery, they are C stage, CT whatever, CN stage whatever, CM stage whatever. The C stands for clinical. Then after surgery, they'll be PT whatever, PN whatever, PM whatever, hopefully M0. And the P is for pathologic or post-prostatectomy. And with the lymph nodes dissected, you can get a P stage for end status. And the whole point of staging, whether clinical or pathological, is to help guide a patient towards the treatment that they need. So think about what you might do if someone's pathology comes back as PT3, so that's higher stage, and 6 out of 10 lymph nodes come back positive. You might be concerned about undertreatment of the original primary disease. So maybe you might be more inclined to treat them with hormone therapy or radiation. Now, major society guidelines are actually fairly up to date and mostly informed the more recent literature on this topic, with the exception of AUA Astro. And we'll go more into the depth, more in depth about the actual data informing the guidelines today. But they all generally agree with each other, more or less. PLND has a value in staging, but all of them are fairly vague or weak in terms of the specific staging value. So AUA Astro suggests that positive lymph nodes, even with the negative postoperative PSA, can be offered adjuvant therapy. And in terms of therapeutic value, AUA Astro points out a lack of consensus on therapeutic value. They don't specifically differentiate between CN0 or N1 status. The EAU guidelines point out RP as possible in CN1 disease, but they word this very neutrally, pointing out that ADT and RT are conventionally used more in this setting. And then in their flowcharts, the RP is not even given as an option. And then the EAU guidelines also actually, in fairly strong verbiage, deny any therapeutic effect of extended pelvic lymph node dissection, despite the update happening after the recent update to the MSK trial that I just mentioned. And that's somewhat interesting given that in 2024, when the trial was definitely negative, the recommendation then was a strong recommendation for extended pelvic lymph node dissection in high-risk disease at least. Lastly, on the other hand, you got the NCCN guidelines, and they point out, again, with strong verbiage, that there's limited evidence on RP and PLND in CN1 disease, and this should only be used as part of a clinical trial or a planned multimodal approach. Again, no specific comment on the therapeutic value either in CN1 or N0. Lastly, in terms of the approach, if you are going to do a PLND, they all do suggest doing an extended pelvic lymph node dissection. Okay, so why the controversy? There's a lot of decision points in the chain of care when it comes to performing a lymph node dissection in prostate cancer. Any patient needs to be clinically staged before offering any treatments, and higher risk disease, especially CN1, might make you lean more towards radiation, and so wouldn't even do a PLND of any extent. But then how do you stage them? With conventional imaging, 5 to 15% of people might have CN1 disease. With PSMA-PET, you might have 30% with some amount of CN1. Actually, PSMA-PET has a chance 15 to 30% of upstaging you to M1 if you were previously CN1. Anyway, even once you commit to a PLND, there's questions about the extent of dissection. Which side do you do it on? Do you do it on both sides? What can you do to minimize the adverse events? And when you do counsel someone on the PLND, can you comfortably say that there are oncologic benefits or staging benefits or both? Let's talk about the anatomy first, the review of some of the basic science behind lymphatic drainage of the prostate. I see other discussions on this topic bring up the original Gray's Anatomy textbooks, but before Henry Gray and Henry Carter, who was the illustrator for Gray's Anatomy, there was Henry Rouvier, who was a French anatomy professor, who published this lengthy textbook about the anatomy of the human lymphatic system in 1932. And he cites works in the centuries prior to him and piecing together this really detailed and strictly anatomical, non-functional description of the human lymphatic network from the prostate. I used to spend some time doing prosections for an old anatomy department. And the basics of dissecting and identifying lymphatics is probably not changed much in the last century, but you might be surprised to know that there really has not been much else as of late with strictly anatomical evaluations of the prostatic drainage system. So these ancient works are actually still the basis of our primary understanding, anatomically speaking. You can find this book online for free in its original French on the Internet Archive. And apparently this was before they invented the table of contents, so it took me a while to find this chapter on the male genitourinary system out of 500 pages. And my French isn't particularly good, but paraphrasing Rouvier here, he describes that the whole prostate is permeated by these draining lymphatics that then collect into the subcapsular network. And most of the collecting lymphatics exit the prostate posteriorly and close to the base. And they do that in association with the arteries that supply the prostate. But there are also these lymphatics that come out from the lateral and anterior part of the gland. And if you take a look at the drainage of the base, it mostly tracks up along the medial border of the seminal vesicles and then ultimately travels in association with the ureter. So it ends up terminating at the external iliac lymph nodes and the common iliac lymph node region. The drainage of the apex of the prostate is a little bit different. It's described to come up as going up to the base, yes, but then instead of traveling this way, they seem to follow more of a course along the hypogastric nodes, i.e. the internal iliacs. Of a lot of interest, he also describes that the posterior prostatic lymphatics travel heavily along the rectovesical fascia, and they terminate at the parasacral nodes, which is near S2 and near the sacral promontory. And also that there are a lot of nodes that lie between the rectum and the prostate, which wrap around the rectum into the pararectal lymph nodes, which no one's ever going to do a dissection with, but anyway. Anyway, so from the early anatomical studies, there was this paradigm that, there are these distinct lymphatic channels, and, maybe there's some imperceptible crossover from different regions of the prostate into different lymphatic chains. And, since 1932, we've now come across the ability to conduct what we call mapping studies of prostate lymphatic drainage that have allowed us to kind of challenge that notion. So here I have a figure from this 2016 study by Nguyen and colleagues. They took 42 patients with intermediate or high-risk prostate cancer who were already scheduled for a prostatectomy. And then they took ICG, or indocyanine green. Then they injected that into the prostate transrectally just prior to the surgery. And this is a really cool figure on the screen. In the top left of each subplot, you see where they injected the dye. So that's a schematic of where they injected the dye. And inside the surgery, then they used a near-infrared probe to detect the fluorescence from the ICG dye. And then regardless of what they saw, they conducted an extended pelvic lymph node dissection. So for subplot A, there's 12 patients here. And they did a sextant injection. So that's left and right, apex, mid, base. And in that cohort, the predominant drainage is into the external iliac regions in orange, about 50% bilaterally. There's also a good amount of drainage into the internal iliac regions of about 20% bilaterally. And then there's another like 10% that's going into the fossa marseille. So there's actually quite a lot of drainage outside the, might be called the standard template. And I'll go over the templates in a bit. Now for subplots B, C, and D, there are bilateral injections into the base, mid, prostate, and apex. Now, don't stress too much about these specific numbers, but what you can grossly see here is that the specific location of injection into the prostate, apex, mid, base-wise doesn't seem to matter too much. The drainage patterns are mostly preserved from the sextant injection. We don't have confidence intervals for these numbers, but I'd say it's fairly safe to conclude that the paradigm of there being very distinct lymphatic drainage pathways for different prostatic zones just clinically does not bear out. And I would, on the basis of this data, for example, and also other mapping studies, not be inclined to tailor a PLND extent solely on the basis of tumor location. But what about laterality? So in subplots E and F, there were apex, mid, base injections, but they were only done on the left or on the right. And what the numbers are telling us here is that, yes, there does seem to be some drainage predilection to the ipsilateral side of the injection, but there's still absolutely contralateral drainage, overall more than 30% on the contralateral side. And so that's not news to most people, but it is worth mentioning when we get to the putative therapeutic effects of pelvic lymph node dissection. In this earlier mapping study, we're using a technetium-99 scintigraphy and a very extensive lymphadenectomy. Primary lymph nodes draining the prostate were seen to go as high as the retroperitoneum, even above the IMA. And they determined that only 38% of lymph nodes are actually contained within the confines of a standard dissection limited to the obturator fossa, which actually I think is a really good yield for just the obturator fossa anyway. And even if you go and extend beyond this from the obturator fossa into the internal iliac, that only gets you 63%. And if you super extend it up to the IMA, that still only gets you 75%. Anyway, none of this is to say anything yet about whether removing all the nodes is actually beneficial to the patient or not. And no one's going to go chasing up to the head or the rectum, but still. Another thing I was interested in personally was if there was a difference in the distribution of lymph node mets based on your risk category of prostate cancer. So this is a Frontiers paper this time from 2018. It's a retrospective review of 600 patients getting super extended dissections, and 130 of those people had positive lymph nodes. And of the patients who ended up being PN positive, everyone had a predilection towards the extended template regions that would be harvested, the internal iliacs, the external iliacs, and the obturator. But there does appear to be a difference in that there's barely any involvement of the common iliac or presacral if you are intermediate risk. But there is certainly more likely to be involvement if you're high risk. So remember that the denominator here is all just the PN positive. So this is a proportion of those who have any lymph node metastases at all. Okay, so I've been a little bit rude. I realize I've been throwing out terms like standard, limited, extended, super extended lymph node dissection without being clear on what they mean. And I also won't pretend that there's complete consensus to this. But for the purposes of my presentation, a limited pelvic lymph node dissection is just the obturator nerve and what's around it. A standard pelvic lymph node dissection is the obturator and external iliacs. An extended pelvic lymph node dissection is the external iliacs, obturator, and the internal iliacs, up to the ureter crossing onto the common iliac. And then a super extended lymph node dissection is like the extended, but going all the way up to the IMA. And if it is relevant, and that's my way of saying it will be relevant, I will mention if somebody else's definition of limited or extended pelvic lymph node dissection has different boundaries than this. Lastly, while we're in this section of the presentation about the lymphatic anatomy, I figured I should talk about whether the nodes appear to be more or less accessible by open or robotic approaches. And all of the evidence here is exclusively retrospective. And for most institutions, people are really only interested in publishing things like these when their robotics programs are up and coming. So I got the impression here that there's always going to be a slight systematic bias against robotic surgery for lymph node yields. So here's a few manuscripts that are organized by the years of accrual of each retrospective cohort. And it seems that even when you at least cognitively control for the time period of accrual, the largest retrospective cohorts in this space from North American data sets suggest that the yields tend to be better with open surgery than with RELP, but not by too much. Temporally, the most recent cohort is on the right. It's from Germany. And in that group, there was no meaningful difference in yield in the groups. Anyway. Okay, so now that we have a sense of the anatomical and functional drainage of the prostate, we can discuss the treatment strategy of different clinical stages of the cancer. After all, if someone's not getting surgery, they're not getting a PLND. We'll start off with CN1 disease, whether that's determined by conventional imaging or PSMA-PET. Although in general, most of the evidence in the space is going to be based on conventional imaging-based staging. The reality is there's no level out evidence directly comparing RT to RP in CN1 disease. Actually, even in just the high-risk setting, if you attempt to break down subgroups of major trials comparing RT to RP, PROTECT, PIVOT, SPCG4, even just the CN0 high-risk population, though that group will be underrepresented for high-risk prostate cancer, let alone a CN1 population. So for example, with the PROTECT trial, majority of the patients are low risk and not node positive, and they don't even accrue T3 disease or higher, so can't do a subgroup analysis there. PIVOT was only for RP and observation and still underrepresenting high-risk people. In SPCG4, they literally did like intraoperative lymph node frozen sections, and if those are positive, the whole RP was foregone. So the highest risk people didn't get the procedure. There's a number of major ongoing trials trying to fix this gap, comparing RT to RP in high-risk patients. For example, SPCG15, the International PACE trial. There's a couple of trials coming out of the Tongji Hospital in China, but all of these are going to be excluding CN1 patients. So as far as I can tell, the data is not coming. Of course, we do have excellent level 1 evidence that RT works in CN1, and actually the metastatic population too with STAMPEDE. The majority of patients in STAMPEDE enrolled had CN1 disease here. And so the NCCN guidelines reflect this, where RP might be considered in select patients, but really on the basis of STAMPEDE, RT and ADT and abiraterone 2 ideally are the standard of care. And if you are offering surgery, you should be fully prepared to offer a multimodal approach. All that said, we do operate on CN1 disease here and at other institutions. And it's worth noting, well, specificity of conventional imaging is typically quoted as being quite good, 90%. It might still be a bit of an overestimate. There could still be very well be a good chunk of CN1 people getting shuttled away to radiation, away from surgery. But I'm starting to digress. When the level 1 or 2 data are absent, you can always look to level 3, level 4 data. But there's surprisingly not that many retrospective cohorts that assess whether CN1 should be treated with RT or RP. And on a cursory review, I couldn't find a systematic review in this space specifically. So there's a couple of cohort studies I wanted to highlight. On the left is a Kaplan-Meier curve from Tinsley and colleagues in 2025 who undertook an other-cause mortality weighted analysis based on SEER data of almost 5,000 clinically node-positive patients getting RP and about 1,000 node-positive patients getting RT. And with their weighting of other-cause mortality, they found that at 10 years, the RP patients had a risk of about 18% for prostate cancer-specific mortality, and the RT radiation patients had nearly 28% risk, so 10% worse risk. And the matching that they did was intended to adjust for the fact that the average prostatectomy patient is healthier, and you can chalk up the result to an inadequate matching, but the effect size is still fairly big. On the right, you have a German cohort, smaller, from Wenzel and colleagues, also in 2025. And in this group, there's a 230-person strong sub-cohort of clinically node-positive patients. 87% of them had radical prostatectomy and 13% had radiation therapy. And they found that the metastasis-free survival was better in the RT group, even though the RP group was on average younger with lower PSA. And they also did hypothesis testing for overall survival, cancer-specific survival. Overall, from this particular study, I had the impression there were too many analyses being done, and the signal was not particularly strong for the number of comparisons being made. There's a couple more papers on this topic that I've put in like very tiny stuff here, but all of these prominent ones still use the same SEER data as this one here, so I only included this one. Anyway, that's the evidence I found for operating on clinically node-positive patients. So at this point, clinically node-positive or node-negative, you say you've decided with your patient that you will operate. In the intermediate or high-risk population, what is the right way to do a pelvic lymph node dissection, and how far should you go? Is the benefit purely from staging, if even that, or is there a therapeutic effect too? A lot of people will refer to the 2017 Fossati systematic review, and it's a really good review. For those who are unfamiliar, they analyzed 66 studies, recruiting a total of 275,000 patients. And overall, they couldn't discern a direct therapeutic effect for any extent of pelvic lymph node dissection. And the identified risk of bias was also fairly high in the majority of included studies. More red is bad. There's also been a couple of other reviews in the space since 2017. I mean, it is 8 years old. But the one I really wanted to highlight was this network meta-analysis of 16 studies, including 15,000 patients. And they use some sophisticated statistics to ordinalize these variables of doing a limited versus an extended versus a super extended. And for some reason, they put standard outside of these three. And I'm generally a fan of trying to preserve ordinality and continuity in data in your analysis if you can. But in the end, the outcomes were a bit strange anyway. The BCR-free rate was better in the limited, extended, and super extended groups, and then somehow worse in the standard with a limited template. Anyway, I like the figure, but yeah, I just wanted to highlight this. And then another couple meta-analyses I want to point out, which are contemporaneous with the Fossati review, but much smaller than it, include a meta-analysis by Garcia-Perdomo in 2018, comparing standard pelvic lymph node dissection and extended pelvic lymph node dissection. And they found for outcome of biochemical recurrence, they had a hazard ratio of 0.62 favoring the extended template. And then there was another one by Chu and colleagues in 2017, ruling again in favor with BCR as their outcome, in favor of extended pelvic lymph node dissection with a hazard ratio of 0.71. The point being, what I'm trying to say is that there is some signal, even if it's poor, about some oncologic effect in all of these meta-analyses. Of course, the huge problem with any retrospective review in this topic is that extended dissections will always more accurately stage the patient, and then that'll inevitably change their post-surgical course. Now, if you want to ask about level 1 evidence, as we always should, there are two major trials in the space. There's the large single-center 2-year trial out of MSK that I alluded to at the beginning of the presentation, and then there's a Listinghi trial out of Sao Paulo, where they randomized about 300 people to receiving a limited pelvic lymph node dissection versus an extended pelvic lymph node dissection. And their population was 60-40 split of intermediate to high risk patients, and they accrued from 2012 to 2016. Now, their specific templates were just the obturator region for a limited dissection. And then for an extended dissection, they took the obturator, they took the external iliac, they took the internal iliac, and they took the common iliac, and they took the presacral nodes. So I'd call this, quite a bit more extended than what you might expect. So then that really does bear out. There is a real dissection difference of 3 versus 17 nodes on average. And you'd think that if the Hallstedian model is true, that lymph nodes are a reservoir for disease, a pelvic lymph node dissection would mop up the spillage. And then there should be some signal for their primary outcome, which is biochemical recurrence, and avoiding it, but there really wasn't. Their primary outcome was BCR, and it was negative during their follow-up period. They did have a secondary analysis, totally hypothesis generating, where patients with ISUP group 3 to 5 did have a difference in their BCR rates, where 60 months out, the extended group seemed to have a close to 50% biochemical recurrence, and the limited group had about 75% biochemical recurrence. But the P is only 0.24 for this, 0.024 for this difference. And recall that about 40% of the cohort was high risk. And I can think of a lot of ways in which I can iterate on this comparison if I were so inclined to check whether higher risk patients have a worse outcome. And I think in my head for a secondary outcome, this p-value doesn't satisfy my concern about multiple comparisons. Also, incidentally, I want to point out here that for the patients who did end up being PN positive, so it was somewhat odd that a majority of the patients with the PN positive status ended up having their disease in the internal iliac chain. So that would be missed by a standard template. Wow. Okay, so now we finally get to the paper I alluded to at the beginning of the presentation. This is a paper from Karim Tougier out of MSK. They randomized 1,400 patients to a limited versus an extended pelvic lymph node dissection, and their accrual was between 2011 and 2017. Now, the templates compared to the Listinghi trial are very different. Their limited lymph node templates includes the obturator and the external iliac packet. Their extended pelvic lymph node templates includes the obturator, the external iliac, the internal iliac, but no common iliac and no pre-sacral, unlike the last trials template. So there's kind of like a convergence of the templates. And the differences in lymph nodes retrieved from both groups is now, well, less. You've got a convergence of the median lymph nodes collected, and it's 12 versus 14, which is not much of a difference, but maybe those 2 extra nodes are the important ones. With an average of about 5 years of follow-up, in their first 21 release on this paper, they had biochemical recurrence as an endpoint, and they initially reported no differences in the rate of biochemical recurrence between the limited and the extended pelvic lymph node dissection arms. Then in 2024, they released an update with more follow-up, as well as a secondary endpoint analysis for local and distant metastases. Actually, I shouldn't really say secondary. As far as I could tell from their pre-registration of their trial, it wasn't actually listed as a secondary outcome. So really, I would say this is like completely post hoc analysis. But anyway, their primary outcome was still BCR, and that was still negative. They did end up finding a signal in post hoc analysis for metastasis-free survival, both any metastasis and distant metastasis. This is the Kaplan-Meier curve that you're looking at on the side. And what you see is about an absolute risk reduction from 11% in the limited template to around 8% in the extended template for MFS. So that's an ARR, or absolute risk reduction, of 3%. And that's in all comers. So if we try to break it down, first off, the study population is more so of an intermediate risk category than a high risk category. But even still, there's still a healthy representation of people who ended up being pathologic, positive disease, about 12%. And the thing to note here, 12%. And the thing to note here is that, yes, in all comers, the incidence of METs or distant METs is statistically significantly better, favoring the extended pelvic lymph node dissection. But this is basically all driven by the N1 patients. So on the bottom, you have this risk curve that reflects that point that I'm trying to make, which is that in the patients who are N0, whether or not you get an extended or limited template, your curve is pretty low, and also they kind of look like the same curve. And if you look at the N1 group, if you have a limited template, you have a higher risk of metastasis. And if you have an extended template, you have a lower risk of metastasis. If you come back to that ARR of about 3%, if you just do 1 over that, 100 divided by 3, it comes out to a number needed to treat of about 33 extended lymph node dissections to prevent 1 metastasis at around 5 to 10 years. To be fair, the operative time is virtually the same between their 2 groups, so it might not be too much cost. This right figure is also one of their supplementary figures, where they show that regardless of the number of nodes removed, remember 12 and 14 are just medians, there's a persistent gap in the probability of metastasis between extended pelvic lymph node dissection and limited pelvic lymph node dissection. And what that might suggest to you is that it's more about the location of the nodes rather than the number. I think the MSK group has done a lot to try and shoot down their own results and apply a lot of rigor to what is otherwise a post hoc analysis. So here's a graph of the time to salvage treatment from biochemical recurrence. And looking at the curves, it does look like N1s, purple and green, got earlier salvage treatment from the time of BCR. But it doesn't seem like the post hoc MFS difference is driven by a difference between intervention and control here. Because honestly, I see that these curves are more or less overlapping, especially in the early period. And it's also a little bit hard to believe that a medical oncologist would go through the chart and then look up the operative node and the trial allocation, and then make a decision based on like when to start salvage treatment based on that. And it's also a little bit hard to think that it's purely based on the pickup rates of node positive disease, because, well, one, this is just a node positive group, but also the pickup rate for PN disease was the same in both groups, like about 11 or 12%. So there's no staging difference. So I don't think the effect size is dictated by the time to salvage treatment. And also the form of salvage treatment was not so different between the 2 groups, whether split up between ADT, radiotherapy, both, none. Anyway, the corresponding author has also gone on record in saying that they undertook an independent statistical review with a statistician from another department at MSK, and they verified the same results. And then the last thing I'll mention is that the p-value was less than 0.001. So even if you do a bond-for-only correction for multiple comparisons, that's a fairly good signal. So everyone has an opinion on these results, and I think it's not unreasonable to say that with the level 1 evidence where it is, that BCR is not affected by lymph node dissection extent. And that really argues against the idea of PLND being a mop-up for residual disease. So if you aren't mopping up residual disease, and you do end up getting BCR at roughly the same rate, then what is the extended pelvic lymph node dissection doing to improve metastasis-free survival? And the author's main explanation is this self-seeding hypothesis. This is an idea that rather than a single spread in one direction out from the prostate up to the nodes and then up to distant sites, cancer cells move back and forth between all 3 areas. So if you do the extended pelvic lymph node dissection, you kind of cut out more of the environment where metastatic burden can grow. And so even if a recurrence takes place, let's say at the prostatectomy bed, the overall environment in the body is not so favorable to it taking up to metastasis again. There are several critiques of the trial, the first of which is that this is a non-primary endpoint. The findings could be by chance. I will say that the p-value is really quite low. And also there was an independent statistician looking at the results. You can also say that MFS is a really legitimate endpoint. It's not totally gameable. And lastly, I felt that looking at the supplementary, there were a lot of internally validating, corroborating analyses. I'll skip this bit here about this one concern where they switched from one-to-one randomization to cluster randomization. Yeah. And then people might ask, okay, what about the lymph node counts? The number of nodes is important, but the author's argument here is that the location matters just as much as the lymph node quantity. And if we recall that supplementary figure with the lymph node counts, that one. If you recall that figure, then it kind of corroborates this idea that it's about the location and not the counts. And that actually mirrors some of the literature in prostate cancer and even in bladder cancer, where I won't bring it up, but it's not a totally isolated paradigm of thinking. Yeah. Okay, so you've done the pelvic lymph node dissection. You found someone with PN1 disease. Does your improved staging now meaningfully influence the management? I mean, if the answer to everybody post-surgery, PN0 or PN1, is to wait for the opportunity to initiate early salvage to wait, then why are you bothering with a pelvic lymph node dissection? Also, if you have other risk features like positive margins, seminal vesicle invasion, extraprostatic extension, then what does the PN status add on? Well, there are some staging benefits, even if you have those other risk parameters, but I'll address that in a bit. There's 2 points of level 1 evidence I want to highlight here. The first is the Messing trial for ADT, published in 2006. Incidentally, one of the authors is Donald Trump. But anyway, this is very old. He's a medical oncologist. Anyway, this is very old data, but to review, they had 100 patients who were initially T1B or T2, so grossly speaking, more low risk, who ended up being PN positive. And they recruited from 30 sites to gather just 100 people. And they compared immediate ADT to delayed or deferred ADT, with the main outcomes being overall survival, progression-free survival, prostate cancer-specific survival. So really patient-centered outcomes. And they had 11 years of follow-up. And even with just 100 people, the signal was very strong in favor of immediate ADT. But that said, when they did delayed ADT, this was delayed to the point of disease progression, not PSA rise. So the deferred ADT is very deferred. Also, the study is so old that halfway through the study, they were changing from prostatic acid phosphatase assays to PSA. The second paper on the right is the artistic meta-analysis. This is pre-planned meta-analysis for adjuvant versus salvage radiotherapy. So that includes radicals, raves, and GETUG. And mainly, I want to draw attention to radicals because they did have some subgroup of pathologic node positive people. But unfortunately, we're trying to break down the subgroup and see if there's clinically node positive who would benefit from immediate radiation therapy. That subgroup is just too small. So 50% of the people in both groups, adjuvant or early salvage, didn't get any lymph node staging at all, pathologically. And only 5% or less were found to have lymph node involvement. So it's just too small to interrogate that subgroup. And then GETUG didn't get anybody. And I think it was an exclusion criteria for GETUG, and then RAVES had 1 person. So a subgroup analysis for PN1 status for immediate RT is just kind of impossible to do right now. So this is a bit of a recurring theme in the talk, but when the level 1 evidence is lacking, we go to the retrospective reviews. And there's two good systematic reviews, both from Giancarlo Mara in 2020 and 2025. This one here is the 2021. It's a general review of ADT and RT management strategies for pathologic node-positive disease. And to avoid getting bogged down in the details, I'll just cut straight to a few takeaways. One, there's a good chunk of pathologic node-positive men, perhaps like 1 in 3, that won't have BCR in 10 years. Also, the overall survival and cancer-specific mortality at 10 years, if you have more favorable features, is better than 70%. So there's really a large group of people that really aren't too bad off for being pathologic node positive. Of course, if you have pathologic node positivity, you might expect that you would also have PSM, EPE, seminal vesicle invasion, higher Gleason grade, and that's fine. But in this review, it appears that of all of those adverse features, they comment that the Gleason grade and the percentage of lymph nodes involved were the most relevant for identifying those who really were at risk for having overall worse cancer-specific survival and overall survival. And lastly, of all the retrospective trials that align with the Messing trial about ADT, these more recently done retrospective trials did not corroborate the Messing trial. So that is to say, immediate ADT was not better than deferred. The second good retrospective review, again from Mara, is from summer of this year, where and his colleagues identified a specific cohort of 1,100 patients with CN0, M0 disease who then ended up with PN1 disease. And then they saw if adjuvant versus early salvage radiotherapy made a difference. And again, to move quickly, the takeaway was that in a high-risk part of this cohort, 7-year overall survival was 84% for those getting observation, and then 95% for those getting radiation therapy. And it was a little odd, but in my mind at least, but the way they determined high risk was through a custom model where they incorporated pathologic T stage, high subgrade, and node burden. And what I really wish was done here was to somehow control for the presence of those other adverse pathological features, because it's hard to comment on the specific contribution of lymph nodes for staging when someone made a decision to provide radiation therapy on the basis of the other high-risk features post-prostatectomy. But taking the review at face value, adjuvant radiation therapy yielded a survival benefit in those people with more unfavorable risk factors. Okay. The next thing I want to talk about is whether PSMA-PET can, in the pre-surgery phase, can help you avoid a pelvic lymph node dissection. I'm not going to belabor the point that conventional imaging vastly underestimates compared to PSMA-PET's true positive lymph node involvement. Here I have the pro-PSMA study, nice level 1 evidence that PSMA-PET, of course, picks up more in the way of pelvic nodal lesions than conventional imaging. And their population here is exclusively high-risk disease. Those who have read the trial before will recall the excellent test characteristics for PSMA-PET, where they cite a sensitivity for nodes of 85%, which is not perfect, but far better than conventional imaging at 25%. And then they cite a specificity of 98%. I feel that sensitivity is likely an overestimate of the actual sensitivity of PSMA-PET. The reference standard was this composite of histopathology, of imaging, and of biochemistry at 6 months follow-up. And only 23% of the patients had an extended pelvic lymph node dissection in the pro-PSMA study. And so the gold standard, again, was that composite. So if there were missed lesions in that reference standard, somebody has small foci of disease that would have been seen on pathology but weren't readily clinically apparent by 6 months, and it would just stay invisible. And unless this micrometastatic focus that would have been pathologically positive somehow rears its head at 6 months, you would just never know. So here's a study from Stabile, I think so. Stabile and colleagues. It's another review, but this one incorporates 27 studies from almost about 3,000 patients, where all of the studies had intermediate to high-risk patients who had preoperative PSMA-PET. And the question they're trying to ask is, can you use that to avoid the need for a pelvic lymph node dissection? And the risk of bias here was moderate. Green is good, red is bad, yellow unsure. And overall, there were low concerns for external applicability of the data. What most people commonly cite from this trial is the pooled statistics in all groups for whether PSMA-PET compared to the gold standard, like the reference standard of histopathology. They cite the pool statistics, and they fixate on the statistic of 58% and a negative predictive value of 0.87%. And I focus mainly on these two test characteristics, more sensitivity and negative predictive value, because those are the test characteristics that would help you, obviate a pelvic lymph node dissection. If you had a clean PSMA PET scan, then maybe you could avoid the dissection. Now, sensitivity and positive predictive value is still important. You get the PSMA PET scan to pick up, let's say you want to pick up M status mainly, but regarding N status, if you find something, it could guide your dissection anatomically. No nomogram is going to be able to do that. But I'm just focusing on these two for now, specificity and negative predictive value. Sorry, sensitivity and negative predictive value. And going back to those numbers are okay, but unfortunately they're not enough to hang your hat on. But if you break it down between high risk and intermediate risk for sensitivity and negative predictive value, you see that the test characteristics are, for intermediate risk at least, much better for sensitivity and negative predictive value. Sensitivity for intermediate risk prostate cancer was really good. It's 93%. And then the negative predictive value was as high as 96%. And yes, the lower bounds of the confidence intervals are 76 and 86%. But that's still a negative predictive value of close to 90% at the worst for intermediate risk. And there's some prospective studies as well looking at performance characteristics of PSMA and also non-PSMA PET scans, like the Osprey trial, or there's this other trial that does sentinel lymph node frozen sections. But by and large, they didn't include intermediate risk disease on my review, so I won't be discussing them here. But basically, to hammer home the point about the low sensitivity of the eventual pathologic node positive status, all of these other studies kind of converge on sensitivities in high risk disease as low as 40% and about as high as 60%. So let's say that the real sensitivity of PSMA PET is about 40 to 60% in the high risk group. It's actually about the same, if not slightly worse than some classic risk nomograms. And of course, those nomograms aren't going to tell you about any anatomic distribution of the nodes, but just comparing PSMA PET to nomograms for predicting someone's node positive status. There is some interest in trying to combine all the data available into a kind of ensemble model, a third generation nomogram with preoperative MRI and PSMA PET and other features. And this is all mentioned in the EAU guidelines. Inclusion of PSMA PET does seem to improve some novel nomogram test characteristics, but for one of these ensemble models at least, more than one, but for one of them on external validation with a separate Australian cohort, while it beat out old nomograms like MSKCC and the old Briganti nomogram, these ensemble models were about as good as the Briganti 2019 nomogram. So I welcome any other thoughts here, and there's lots to say, but my impression is that in intermediate risk disease, a PSMA PET scan could obviate the dissection given its improved test characteristics in that subgroup. And if you're a believer in the two-year trial's purported effect, though, I guess it doesn't really matter because you're likely to not be node positive and see the benefit of improved metastatic-free survival for intermediate risk anyway. In high-risk disease, a PSMA PET is uncomfortably likely, I'd say, to miss a lesion that could yield some benefit if removed and also help with downstream staging. And if the PSMA PET is negative, you could combine it with other preoperative features, but it looks like there's not that much extra benefit to be gained by doing this ensemble model compared to just a good second-generation nomogram. So I might not avoid doing a pelvic lymph node dissection if I believed in the utility of one just on the basis of a negative scan. Of course, there's going to be lots of schools of thought here, Australia, Italy, MSK, but just a lot of things to think about. Okay, so I think it's time to start trying to piece together the whole puzzle, or try to at least. To get a sense of the complication rate for lymphedema, two big ones are lymphedema and lymphocele. And to get a sense of the complication rate for these two things, many people will reference retrospective reviews on this topic. And the 2017 Fasadi review that I mentioned earlier does suggest that there are going to be worse outcomes based not only on doing the pelvic lymph node dissection, but also proportional to the extent. So the bigger the extent, the worse the complications. This is a screenshot from a webinar from Johan Strahm. But to get a sense of the numbers, the chance of developing a lymphocele is sometimes quoted in the range of approximately 10%. And the chance of developing a lymphedema, which certainly a clinically relevant patient-centered outcome, could be as high as 4 to 10%. The pictures that are here are from the patient of the presenter. He makes the point here that this patient's life is ruined from this complication. So I did have to say, though, that if you go back to the large 2-year trial, the incidence of adverse events was really, really low. And they didn't have any grade 4 to 5 complications. And for grade 3 lymphocele and chyloscytides, you had more events in the limited pelvic lymph node dissection group. Of course, there wasn't much of a dissection difference, but still. And if you look at DVT, you look at intra-abdominal infection, you look at pulmonary embolus, there's very low event counts. And this is a large 1,400 strong trial. This is high quality prospective evidence for that. There are some ways to mitigate the lymphocele and lymphedema risk. The Pelican trial was a prospective parallel, double-blinded, well, probably referring to the patient and the analyst, hopefully not the surgeon, randomized controlled trial from 2019 to 2021, where the authors did this bilateral pelvic flaps. And to create the flaps, what they did was they took the ventral peritoneum and they incised it bilaterally, and they flipped it over and fixated it to the pelvic floor. And their primary outcome was symptomatic lymphoceles in 6-month follow-up. And they had a very positive effect. So they had a big effect going down from 9.7% of symptomatic lymphoceles down to 3.7%. So it's a p-value of 0.005. And the cost of this was just 11 minutes of OR time and really no other complications. The study was published in 2024 and it's mentioned in the recent EAU guidelines, but there's no specific recommendation that this be used if you're doing a pelvic lymph node dissection. There also are some other strategies that could play a role in minimizing morbidity, like sentinel lymph node biopsy and radio-guided pelvic lymph node dissection, but I think right now that's out of the scope of my presentation. Okay, so you might be thinking at this point, it would be really nice if someone did a cost-benefit analysis of some kind to tell me, what side I should fall on. And so this study is actually ahead of print. So I'm showing the accepted but unedited paper here. Thankfully, the lead statistician and epidemiologist out of the MSK group for the 2-year trial did this for us from Dr. Vickers. And what they have here is this decision analysis of what happens in different circumstances post-prostatectomy. Getting a pelvic lymph node dissection, not getting a pelvic lymph node dissection, getting a lymphocele and being positive for metastasis, getting a lymphocele and not being M positive. And in their decision analysis for whether you should do a pelvic lymph node dissection or not, they tried plugging in a number of different numerical estimates for the risks and the benefits. And to make a long story short, even with risk estimates that were very unfavorable to doing a pelvic lymph node dissection, using a very high rate of lymphocele and virtually no benefit to metastasis-free rate, the expected utility of a pelvic lymph node dissection was always just higher than not doing a pelvic lymph node dissection. The one exception that they point out is in grade 1 disease, but how often are you operating on that? Anyway, so to wrap up, I wish I had an easier time coming up with some concrete conclusions. I think a safe exam answer would be to engage in shared decision-making with the patient and to discuss the step of the procedure with them. And I do think on my review of the literature, if you are going to use PSMA-PET to skip a pelvic lymph node dissection, if you are going to do that, it would work better in intermediate risk patients. If you are going to do a pelvic lymph node dissection, it also seems to make sense to just go with the extended template, including the obturator, internal, and external iliacs as a good bet. There is staging value, it seems, and it does help dictate post-operative planning. And the benefits in decision analysis, at least, seem to outweigh the risks, even if you have very unfavorable estimates in favor of a pelvic lymph node dissection and very unfavorable estimates against getting a lymphocele. Anyway, that's it.